there. My name is Dr. Kimberly Ernest. I'm a licensed psychologist and licensed professional counselor. And today I am here with Luis Bianco, who is a registered nurse, a certified recovery specialist. And today we're here to have just a really authentic conversation about the state of mental health. Luis's views do not necessarily represent all of the views here of Pennsylvania Counseling Services. However, we're hoping to dive in and take a deep dive of the good, the bad, the ugly, all the different pieces that go into creating the mental health system here in America, and most importantly, here in central Pennsylvania. So where should we begin?
I guess I should say I'm a certified peer support specialist.
What did I say? Recovery specialist.
Just
Goodness
so that I'm
gracious.
not stepping on any toes.
No.
I don't want to. Yes, my name is Luis Bianco. I'm diagnosed with bipolar 1, also PTSD at this point. I'm 42 years old, and I was first hospitalized at age 15. So for 27 years now, I have either been a patient, a professional, an advocate, or somehow involved in the mental health system. And that is forever going to be over half of my life for the rest of my life. I'm in it. I'm doing this, and I have no plans on stopping. It doesn't always pay the bills. It's not easy, but it is something I have devoted my life to. So, like I said, at age 15, I was hospitalized for the first time. I was an incredibly gifted child. I was back in the early 90s. Your parents didn't get to say, I think my kid's gifted, test them. The teachers recommended it. I went to a guidance counselor. They tested me. I don't know my IQ to this day. My mom didn't want me to get a big head. That is a recurring theme that sometimes was detrimental. But I was put into the gifted classes, and I had IEPs and things like that. I was naturally athletic, naturally creative, and up until 8th grade, I was the lead of the school plays, captain of the wrestling team, and top 10 percentage GPA as far as the rest of my class. By 9th grade, I was asked to be on the varsity wrestling team and unable to finish the season because I started to starve myself, not under any pressures of my coaches, by the way. Wrestling and the mentality I learned from that sport is one of the reasons I believe I've been able to maintain a recovery and hold on during difficult periods of time. That sport helped me learn a lot about myself. But I ended up hospitalized due to self-harm. And I think it would be interesting to say right off the bat that a lot of what I showed early, they believed that I had borderline personality disorder, some traits of obsessive compulsive disorder, and also the eating disorder. All of those things back then still were considered female. The majority, only female would have these types of behaviors. So, we're talking, I guess 1998, 1999 is the beginning of this journey for me. And there were no teachers prepared. There were no parents prepared. This was still a very lost art.
But I think it's still very relevant today because we currently live in a culture where there's still debate about whether or not early screening has a place in the school system, whether or not teachers and guidance counselors should be educated in that area.
Yes.
And so I guess my question for you in that space is, I know that, I'm sorry, how old were you when you were first initially
15.
hospitalized? 15.
Yes.
If in that very first age range, like that 8th grade, so you would have been 13, right?
8th grade, I think 9th grade, I was the first time. I don't know age.
Age
I know
is
year.
tough.
Yeah, I might have been going on 16. It was 1999.
Okay.
1998.
If you would have had earlier screening, and if we would have had a better, a more embedded mental health system, do you imagine that would have shifted any courses for you?
Here's what I would say to that, because I think about it a lot, and it is a debate. I think that screening is kind of like testing, right?
Yeah.
And if you test people without giving them information, a lot of people are going to fail the test, right? It's like a pop quiz on the first day without any lecture. That's not fair. So who knows what my early screening would have looked like because I had never been given any education. I still think that holds true today. If we are not going to implement some sort of education process on general wellness practices, ways to manage stress, ways to communicate emotion, but we're going to test people, I think that would elicit results that would be somewhat inaccurate. And it might make us think, oh my gosh, a large population of our youth are sick. Well, no, We taught healthy eating, right? We taught dietary practices before we tested people for coronary artery disease. We didn't teach them about all of the negatives that could come from a poor diet. We first taught dietary practices, something like the food pyramid. I am aware that that is probably no longer accurate by today's standards, but the attempt was educate first. So I believe screening is only appropriate if there is education along with it. And if it was in 8th grade, I mean, I had a low self-esteem, but I was also successful and confident. I had cried throughout my life. I needed to go to the guidance counselor a lot in elementary school. My mom had to drive me to school. And a lot of that was from not being treated at the cognitive level for where I was cognitively because of my age, right? So if something upset me because it didn't make sense, legitimately, it really didn't make sense. Someone would yell at me. I would say, stop yelling. They would say, I'm not yelling, right? That's just a very generalized example. If they really were yelling, you're now telling someone who's of a certain intelligence that what they're seeing is actually not occurring. That it's like accruing confusion. And I believe by the time I got to 15, there had been so many things that I felt a need to discuss that were either dismissed, undermined, or in general not taken seriously because of my age, that I had massive amounts of confusion. And I do believe that can happen. You have to kind of meet people where they're at. You can't just look at their age and decide if what they're saying makes sense or not because of their age. The question just needs to be, does what they're saying make sense? So a lot of things were discredited for me, most likely because of my age, but I was actually accurate in what I was assessing. So I do believe that led to those initial diagnoses or need for hospitalizations, the behaviors, hospitalizations, the stuff that led to it. But I don't know that I would have pinged a test, depending what the questions would have been. I didn't have a lot of anxiety. I was charismatic. I won most musical. I don't think I would have popped.
Okay.
I don't think it would have been seen.
So in that early season, tell me a little bit about that emerging diagnoses and
Sure.
what that was like.
It's incredibly embarrassing. I started varsity wrestling all 4 years, never finished a season. If you were to look me up, I wouldn't show up on any searches as like I didn't get to participate in the end of season tournaments like sectionals and districts and states. So I earned a starting position all 4 years, but never finished a season because I always ended up hospitalized. They thought it was seasonal affective disorder, along with other things, mood disorder, not otherwise specified. So it wasn't bipolar immediately, which I think is good to not label early. I do believe in kind of waiting till that kind of 18-year-old age range before giving it exacts. But school was often self-harm, self-deprecation. I won best sense of humor my senior year, but I would let people punch me. I would let people spit on me. It was like, was it really funny? Yeah, I guess, to everybody else. But if someone had a keener eye by that point, if I had taken tests, I'm sure I would have popped. So I would take plastic silverware, go to the bathroom, cut myself, and then end up in the guidance counselor's office again and again and again, and calling my mom while she's at work because she was also a teacher. And I can't imagine what her life was like. She would be a great interview as well because I was constantly interrupting her day. And I remember one time we were on a major road and I opened the door at a stoplight and it was a highway. And, she gave me the benefit of the doubt often, but there was no telling what I would or wouldn't do because what I was exemplifying was not the person she knew the whole way up to this point. So it was a lot of back and forth into hospitals and out of them. It was schoolwork being sent to the hospitals. An interesting story, when I was first hospitalized, I was on an adult unit. I shared a room with a 40-year-old who was getting ECT. There was an 80-year-old woman who was dragging a suitcase around talking to herself when my family came to visit. They didn't have as many units for teens then. They found a unit for me, but my initial hospitalization was with adults. It was all incredibly confusing. Tons of people were trying to help, but most of the help was, you have a great family, you have good grades, there's nothing wrong with you, while I'm saying there's something wrong with me. So we're getting back to that. Nobody is believing me. And perception's a big part of what I talk about. I think it is the ruination of offering appropriate care if it's used incorrectly. And it's also such a power depending on which position you're in. If you're a doctor, your perception determines my freedom. If you're a teacher, your perception determines whether or not I get detention or I get to go to the guidance counselor's office. If you're a parent, your perception decides whether or not you believe I'm a hypersensitive child who's exaggerating, or you believe me and recognize that I'm in severe pain. Nobody has ill intentions, but just think about, you have to make snap judgments on things, and those judgments truly do carry a lot of weight. So I felt at the mercy a lot of others.
And so you had mentioned that they had initially put you on an adult unit. Was that because there weren't adolescent
I have no idea.
options? You have no idea. They just,
No.
that's just what happened.
That was where the bed was. And within a couple of weeks, I did end up at a place. But there was only one place at that time that had an adolescent unit. So I needed hospitalization. The time that it was the worst, I had cut myself from my forehead to my abdomen and my arms over 100 times superficially. And I was lying on my kitchen floor. And again, I'm going to say this right away. I rarely divulge this level of intimate detail because I think it stinks that people have to go into the into the darkest places of their suffering in order to be received as credible for their illnesses. And I rally against that so much that whoever's story is the most sensational, they get to be the person who gets to talk to parents or stand on a stage in a high school. It's incredibly frustrating as someone who kind of refuses to share the deepest and darkest moments. I do not believe it needs to be required in order for someone to believe whether or not my experiences were terrible and valid. And often when we go into detail, we then isolate other people who are suffering because they're going to listen and they're going to think mine isn't that bad or mine is worse, right? That's perception on the other side. But that comparison does nothing to help people get better. So I often try to speak vaguely. I don't want to in this, but when I speak publicly, I often speak vaguely because I want as many people to relate to the emotional experiences, to the feelings of confusion, and I want them to be able to discuss at a level of being able to relate, not at a level, now you're just watching someone who you've decided's life is harder than yours, or you've decided your life is harder than theirs, and you're kind of checking out of the discussion. And I think discussions are so important. So I do want to say up front that I'm going to share some details that I've never really shared, but it is not a common practice of mine when I speak publicly because I respect the emotional suffering of anybody. If you tell me you're suffering, I believe you. You don't have to tell me all the things you did. You don't have to, we don't have to get into those war stories to see whose is worse. I hate that. I hate comparison. I don't believe it's helpful in any way, especially on the recovery front.
I think it also, exactly what you just said, it creates that separateness. And where I often see the space for connection is in that opportunity within the experience. So while our unique individual narratives very rarely are similar, the experiences within the experiences is where the power of the collective lies, I think. Like that is where, so I've never had that experience, but I felt helpless and hopeless and lost and terrified and alone and powerless and, grief and like all of those different pieces is sort of, and I think recovery relies on the collective. Not on the individual or not on the separateness. And so I really honor, and so as we proceed today, if at any point in time you say, you know what, I don't really want to go there, or I would rather not divulge that detail, just say like, Kim, no thanks, and then we'll move on from there. So I just want to
glad you
lead
said
with that permission as we continue.
Sure, because I do think, and I know we're going to talk about this a lot, but I believe that the direction that we're headed in mental health is that everybody needs to feel like theirs is 100% different. And even though positions like the peer specialist originally existed where you could say, I've kind of been there, right? You can never tell someone you've been there, but you used to be able to say, I've kind of been there. I know what you're going through, even though I can't know exactly what you're going through. You have to be very careful with that in this day and age, because many times if you try to relate to somebody, you are now robbing them of what they believe to be a completely 100% unique experience. But I do agree that it is actually in the shared experience that recovery actually exists, where we can all say, I've felt that. During a different situation, I felt those feelings at that intensity. Because you don't want to feel alone, but we are growing towards people needing to feel like it's only them. At the same time, health actually exists in knowing you're not alone. So that's a really difficult balance to help someone not feel alone and also give them that unique, this is yours, this isn't anybody else's. It's very difficult, and it's a juggling act. It's one of the many juggling acts that a peer specialist has to engage in now. The position was originally created to have someone on the unit or anywhere that's telling someone, hey, I'm kind of walking this path too. But the way you have to say it now is so different than earlier on.
Oh, yeah. And I think that's another reason why I value so much the peer, the recovery support model. Because in my role as a therapist, it's inappropriate for me to lean in the same way.
Yes.
And I think my professional boundaries, and I often will really spend some time there with early career clinicians and supervisees. Like, that's not our role. And for us to go there with our clients causes us to operate so far outside of our role that I think it belies our effectiveness within our role. And at times that's not well received. They're like, oh, but self-disclosure works. And it's like, it may work right now, but there are times where there are a lot of long-term threads that you don't always know the impact of that self-disclosure until you arrive there. So, and I would argue even in the peer support model, there are times where self-disclosure, I would assume, are wholly inappropriate.
The way that I practice is I would like to talk about myself as little as possible. It is my opinion that the peer support specialist is the professional listener.
Yeah.
This is your space. If I need to share 2 or 3 minutes so that you know why I'm here, I'd love that that's all I need to share. Maybe little snippets. Oh, wow, I can relate to that. Go on, right? It is not a place for me to now have a soapbox where I go in and I have someone who's on the other side of crisis just listening to me talk about me. That is not the intent, in my opinion, of the position, of any position actually in mental health on a treatment team. I've only worked inpatient, so I can't speak on much more. But an example based on what you're describing as far as boundaries is, if anybody ever needed taken down, all right, they get escalated, we end up needing to go hands-on. If you are a nurse, if you are a therapist, if you are, anyone other than the peer specialist, you might have to be engaged in going hands-on. If you've used that self-disclosure to develop a trust and rapport, and now you're going hands-on, you are ripping that apart.
Yeah.
That is why people have to be very careful with who discloses, and that is why the position of peer specialist exists. I'm going to establish that with you. I'll do my best to calm you down before people go hands-on, and I'll do my best to debrief with you after they do, but I'll never have to go hands-on. So that rapport that I build with you is never at risk. And one of the issues I run into in this position is that at any given time, other staff would believe that the peer specialist should be the authority. No, you're literally a peer. This job best exists if there are other people around. So if something happens, someone other than the peer can say, hey, you need to stop that. The peer is meant to be a peer. And I don't want to sound like a broken record, but you don't want to blur lines, because that rapport to people who are in vulnerable states is very fragile. And there's a number of different ways that it may require being broken. Even something like setting a boundary. Hey, you need to stop doing that. Get out of my group. a therapist would have to do that. You don't want your peer specialist to have to do that. And you don't want to put them in positions where they would have to do that, because there goes the rapport. It's necessary in some of the most extreme cases, but otherwise you would like your other staffers. And then, yeah, you might not be their favorite, or they might not like you as much after that moment, but you're their clinician. You're there to care for them. You're not there to be their favorite. So disclosure, it's kind of like low-hanging fruit. Yes, it'll get you closer to them. Sure. It'll get their trust immediately, but is it appropriate? I don't know that we're asking ourselves that. I think we just immediately believe this will help. And
and that's often exactly. My metaphor is always, it's like wasabi. Like a little bit will take you a very long way. Exactly. And it often burns.
Yes,
so
right.
Look out. As you were describing it, those initial hospitalizations at 15, and then through, it sounds like it characterized a fair bit of your adolescence, but it took some time for them to arrive at a more accurate diagnosis.
Yes.
I suspect also during that time, there was some, and I don't know, I don't mean to assume, but in understanding bipolar 1, I know that medication management is often one of the most effective treatment modalities. What was your experience with prescribers during that time, and how did they figure out what was going to be most effective for you? And then I know also one of the things that we were going to talk about has to do with like controlled substances in that space and different things. So this sounds like it might be a good place to arrive there.
The controlled substance thing was not as much of an issue when medications first started. So I was put on different benzodiazepines for anxiety initially. A lot of my early treatment was just depression.
Okay.
But then also antipsychotic. I really have been on every type of medication. Antipsychotics, antidepressants, anti-anxieties, anticholinergics sometimes, the different things that they try there, mood stabilizers, everything across the book. I've had sexual dysfunction as side effects. I've gained weight and been pre-diabetic because of some of the antipsychotics. You know, you find stuff that works. Yeah. I've always been like, this is such a tumultuous and terrible experience that if a medication works, I accept the side effects. And that's my belief. Again, this is where we kind of get into that insensitive advocate, which is kind of what I've been labeling myself lately, because I realize that some of the things that I believe I'm saying rub people the wrong way. But this experience is so terrible that if I gain weight, but I'm able to do something like finally graduate nursing school after having to drop out twice and dropping out of college before that, and this medication has me stabilized enough that I can do something like that, then I'm going to gain weight because I am in a better place than I was. Am I happy about the way I look? No. Is it embarrassing and detrimental at times to my self-esteem? Yes. Am I better than I was illness-wise? Yes. So I have never liked these things, and I have spoken to my doctors candidly, like, can we look for something else? But I would never say no if it works, because I've always, for as long as I can remember, I just want to feel better. I just want to feel better. So I am not one of those people that would dismiss every doctor. I thought lots of doctors were insensitive. I've worked with doctors who weren't my gender. I've worked with doctors who weren't my race. I never was selective for doctors because they were people who knew things that I didn't. I needed help, and it was their job. Did I think that they all did it right? Absolutely not. Would I be in the car going home with my mom saying how I thought they were rude and insensitive, or how she thought that? Yes, but their job was to prescribe me medications. And my hope was that those medications would work. That was everybody's hope. So I think my experience with doctors was maybe a little different than other people might describe, because I would try anything. And I have some issues that we can talk about now in my adulthood from 27 years of treatment and putting things in your body that need to be processed and metabolized. Literally, 27 years is a long time to be taking something 3 times a day when you really think about that. And, who knows? A lot of the things I'm diagnosed with now on the physical end are idiopathic. I believe which means we don't know where it's coming from. And I'm always like, well, couldn't it be because it's been 27 years of taking pills. But to get back to the experience, I would just say it doesn't need to be pleasant. I guess that's what I'm trying to say. Because nothing is more unpleasant than being in the throes of something that feels like it's beyond your control. Sabotaging the progress you've made because of impulses that you can't stop. Like this is, by the time I wasn't supposed to really graduate high school, or it was like 50-50, right? It started to not be expected, but I had the ability to. I had all of the tools necessary, but I was really all over the place. So when I graduated high school, I graduated with honors, even though I did a lot of my schoolwork in hospitals. Then I went to college and started experimenting with drugs for the first time, and I dropped out of college with a 4.0. I had a 4.0, but I was also walking around with sunglasses because I punched both of my eyes repetitively until they were both swollen shut. And I shaved my eyebrows off during a drunken stupor to make people laugh. So I'm walking around carrying a 4.0 and literally like just imploding. And people are just looking at the grade. Or I'm the life of the party, so it's a lot of fun. Friends aren't concerned at all because I'm a lot of fun. But then, all of those things are sabotage. I'm sabotaging something that I wasn't even expected to achieve. So I end up leaving my first stint in college. And that was one of the only times I had a suicidal experience. I had all of my pills in my hand. I don't remember what medication it was. I was drunk, very drunk on liquor. I was in my dorm room, and I called my sister bawling. My roommate was scared. It was someone I went to high school with. And they didn't kick me out for being drunk, but I had to start seeing a professional on campus. Ultimately, I kept drinking, and alcoholism became an issue that carried through. But as far as medications, I never abused them. I just prayed that every one would work. I just wanted something to work. And I took the bad with the good.
How do you respond to, and this has always been very hard for me as a professional, and also as somebody who has been diagnosed I was diagnosed young and then throughout my lifetime with ADHD. And I think a true indicator of ADHD is whether or not you like amphetamine medication. And I hate it. And so I've been very frequently told, well, if you would just take your Adderall or Vyvanse or whatever it is, you could remember to do the shit you need to do. And I don't want to take any of that. And I don't take any of it. There have been times in my life where I've had to, to get to the next checkpoint. But at the end of the day, the mood symptoms for me are quite great. So I have the impact where when I am coming down off those meds, I get very sad. Very sad. And so if taken in succession, I experience a depressive episode then.
Sure.
But also I just didn't like the way I felt on them. It took away all the me that was to be.
Right.
And otherwise I think I'm a pretty good time, but not on an amphetamine that just took out all of the fun parts of my personality and made me super focused. And who wants that? So I would rather white knuckle it. And I think I do an all right job with it. But throughout the course of my career, I've encountered other professionals that have a very hard time with treatment-resistant clients.
Sure.
And we'll almost say, well, if they're not going to take their medication regimen, or if they're not going to follow X, Y, and Z recommendations, then I wash my hands of them.
Yeah.
Or I'm not willing to, and I recognize your belief structure has always been, whatever that side effect is, it's better than this, so I'm willing to try it. And my experience was kind of the opposite. That side effect is I would rather forget an appointment than that side effect.
Yeah.
And my symptoms offset that, right? So I can say that, and I have the privilege to say that, right? But I've often really struggled when I come into contact with another professional who knows better than the client experience.
Yes.
And when the client says, that side effect for X, Y, or Z reason is not worth it to me, and therefore I want to go back to the drawing board, and I want to start again, and I want to try again. And when I encounter the professional who says, nope, I can't help them then if they're not willing, it evoked something in me that I'm not often proud of.
Sure.
It frustrates me. So what is your take on the treatment resist? Obviously, I have an opinion, but what is
Yeah.
your take on the treatment resistant client, and how do you approach them?
I will forever believe there's a difference between wants and needs.
Hmm.
And unfortunately, there's a lot of things we don't want. But if we're in a position where we need help, if we are unable to function, if we are literally unable to get ourselves out of bed and be productive in any way, and we are coming here because we are saying our life isn't worth living and all of these things, and we're saying that this is a terrible, I hate this life, right? Or any type of suicide. And then someone says, try this. No. Right?
Yeah.
That is difficult, I would imagine, as the person prescribing it. Because now you are saying, I can't do this, I hate this, and I also won't try something that might work because of an undesirable effect. So I was always, I don't want to say submissive, but I was always compliant. I think it's part of how I was raised.
Okay.
I've always been afraid of rules. So I never thought to argue. And I've had friends say, you kind of did this to yourself. You could have told them to fuck off. Well, I never thought of that. I didn't. For one, it's not in my nature. And two, I believe that those behaviors would further make someone think I was sick, at least in my position. If I was to become argumentative, oppositional, or defiant with a physician, they might just decide that that's not me verbalizing a preference. That's my symptoms getting worse. Now I'm 302. There was one time when I was hospitalized. It was during a manic episode. I told the doctor I was hypersexual. I was a serial monogamist. I wasn't cheating on the people I was with, but I was in like 3-week relationships, back to back to back to back to back. And he decided that he was going to double my lithium. And I said, I don't want that. He said, well, you'll either let me double it or you'll get 302'd. Right? And that was the first time that I ever tried. I was in my 30s at that point, and I was like, I don't think that's necessary. I don't really like what lithium's already doing to my physical body. It wasn't about, it was about physical health. It wasn't about personality changes. It wasn't about looks. It was like, I already don't like, I have to do blood work. My labs are already trending high.
Yeah.
I know the long-term kidney effects that I might have. I'm scared of doubling a dose that I believe is already high. Well, then you'll get 302'd. Right? So
For hypersexuality.
mania. I told them
mania in general.
everything
Okay.
that they decided was mania. I wasn't suicidal. I checked myself in, but they still had me on suicide watch for over 48 hours. Even I verbalized that I was not, like, I was telling people I was okay, but I had security at my bed while I was in the ER, and I had done nothing but walk in, check myself in, and ask for help. Right? So that goes back to perception. Either way, when you are in a place of rock bottom, like really rock bottom, which is what I would consider the inpatient, not that you shouldn't be there, but your illness has taken you to a place that you require hospitalized care, where you are surrounded by medical professionals and you aren't allowed to leave, just like somebody on a cancer unit, just like somebody on a cardiac unit. And it's because you're saying these issues are that severe. I would be curious if you had a cardiac arrhythmia and they said, here's the medication you need to take so your heart doesn't explode. It might cause you to gain weight, or it might make you a little more drowsy, and you might not be as bubbly as you were. How many people would treat it the same? And I do like to go into comparisons of the physical, because I believe that it's time for as much awareness as we've done. If we are going to call this an illness, and if we want to be treated like we have an illness, then we have to act like it's illness.
Yes. No.
Okay, so if you have pneumonia or the flu, that antibiotic might cause you GI distress. And you might not want to be on the toilet for 3 days straight. But guess what? You need it because you can't breathe and you have a virus. Do you know what I'm saying? So that is where I would push back on the treatment resistance. The other thing I would say is at 15, I had no reason to be treatment resistant. I knew nothing about what I was going through. I hadn't been through therapy at all. I hadn't done any reflection. I was in the dark. So I needed help and I knew nothing. At 42, after taking all the meds I've taken, having electroconvulsive therapy as many times as I've had, if I'm not allowed to have a say now, I would be more argumentative.
Yeah.
But it's because I've put a lot of work in.
Yeah.
So I don't think you just get to show up that first time and tell a doctor no to everything without having done any of the work. And it is work. It's more work than a lot of other ailments it's tons of work. So yeah, I've never been oppositional. I've never been defiant. And I do have a little pushback on that. Not that one's right or one's wrong, but if I have an illness, right? If I'm in pain, I take ibuprofen.
Mm-hmm.
That's what we do. So if this is as terrible as you are describing it, and someone says this might help, and you say no, I can see that being frustrating to the physician for sure.
Yeah.
Yeah.
So we've talked about some of those different seasons and stages. I want to talk about sort of the state of mental health care in today's culture,
Yeah.
and how do we create a culture that leads to people. I operate from the assumption that when people are seeking mental health care, that they can tell pretty quickly within a moment of meeting their helper whether or not that helper trusts, likes,
Sure.
honors, respects them. And I think in the absence of that, I don't know that the helping relationship will be all that helpful.
Sure.
And I think most folks, especially those that come from very historically marginalized or disenfranchised populations, which is who we tend to serve at PCS for the most part, right? I think those folks are even better attuned, have like almost this sixth sense, the spidey sense, if you will, where they can really read people really quick. And if they show up to a helping relationship and that helper doesn't have some sense of like respect and hope for them, I don't know. I don't know that they're going to get very far. And yet I think there are times in which our field is lacking in certain areas. And so what do you say to that? How do you approach that? How do we address sort of this endemic lack of maybe not empathy, but how do we create that space or safety
I would
within
say,
our field?
like, we're doing this to ourselves. First off, okay, we are generating a belief that kind of affirmative care, self-affirmed care, where I'm going to try to dictate what I believe is best for me, is more and more believed to be what helps people get better in the mental health field, while we're also creating more and more restrictive regulations and red tape preventing physicians and other medical professionals from doing that. So you're telling people that they are allowed to have all these preferences and privileges, and you're also prohibiting people from offering them anything beyond a certain boundary. And I can speak to this if we're talking about seasons in my life. I just lost disability 3 years ago in October. Okay, so I actually ended up on disability. My hair started to fall out. I told a number of doctors I didn't feel well physically. They all attributed it to my mental illness. Your anxiety creates pain, and then pain makes the anxiety worse, and the anxiety they all made these snap judgments. So I ended up having to pay a concierge doctor when I won my appeal for disability. And what she found is that I have severe issues with my blood. I have very low platelets. I had liver issues. I had kidney issues. All of these things that I was feeling were real. And the only way I could have $2,500 a year. So I make all that back pay from the appeal of disability, and now I'm paying a physician, and that physician's willing to draw blood. Okay, and what she sees in that is that a lot of the things that I was experiencing were actually true, but I'm having to pay that, right? Not everybody has that kind of money. I don't. And when I lost that money, I had to start seeing a PCP again. I didn't lose it, but over time, you're spending $2,500 a year. I'm starting to get healthier. I'm on disability. The way I describe disability, you have an assistive device like a walker. You stand up. People are like, oh, you can stand up. And they kick the walker out because they're like, look, you're standing. So, I don't want to get too far out of bounds. I promise that this leans its way back in.
Oh no, we could talk about the state of
but
disability.
But this is
SSDI for days.
I started to write books. I started to volunteer I looked for jobs, but I wasn't going to put myself in any position to get sick again because I was physically unhealthy for a long time. And I got a little bit more of those preferences and that empathy and that hope that you're describing, but I had to pay for it. When I went to the PCP, she took me off a controlled substance that was helping me with a neurological disorder that I also developed. I now have a stress-induced neurological disorder where if I feel great stress, my muscles tighten and they twist and I get knots all over my body and I get like this. And when it gets tight in my chest, it's hard to swallow. It's hard for air to get out. It's hard to breathe, right? So this doctor decides I don't need that medicine. She said, your other doctor gave me notes, but I'm not even going to read them. And she pulls me off of Valium, which is anti-anxiety, which helps reduce the stress, and also anti-seizure, which helps reduce the reaction. It's the appropriate medication for the neurological disorder I have. Within months of her removing that, I am back in the hospital, not the psych hospital, but a cardiac unit. And now I have a left ventricular hypertrophy. So I have an enlarged heart now. Okay. I had a wedding that was also coming around that time. And my uncle, as a wedding present, gave me enough to go back to that doctor, the concierge doctor, who put me back on the medication. And now here I am. I was also losing disability at that time. So this is where it kind of gets to what you're talking about. I had to sit in front of a physical doctor for 20 minutes and a mental health doctor for 20 minutes. I had lived with this ailment for 20 plus years already. It took me a long time to be deemed disabled. Okay. Within 5 minutes of the physical assessment, this doctor had me holding a teddy bear. He asked me if I could zip the teddy bear's jacket. He asked me if I could tie the teddy bear's shoes. I told him that I had a neuromuscular disorder and that I had seizure-like activity when I experienced great stress. He's like, what kind of seizures are they? I said, I really don't know. They're in my doctor's notes. He's like, no, you don't. 5 minutes of a 20-minute interview for the physical doctor, and then a 20-minute talk with the mental health doctor. I know I'm going to lose disability. There was no empathy and no hope. And I told that doctor, I came in with my shirt tucked in. I shaved. I am not going to pretend that I'm something I'm not. And I'm aware that you're going to perceive me as intelligent and you're going to decide the rest of my life based on 20 minutes, even though I've been doing this for 20 years. So I ultimately lose that. Now, when I'm in the cardiac unit, I don't have disability. I don't have benefits. I was given the opportunity to appeal, but if I lost the appeal, all the money they would pay me during the appeal, I would have to pay back. I was trying to keep a car. I was trying to keep a phone because I was still looking for appropriate employment. But I knew that I shouldn't appeal because I also want to keep trying. So this is where it comes back to what you're saying. You get to decide if someone's trying means they're not sick. You get to decide if you think that someone's illness is actually just them not trying. You get to decide all of this stuff. We call it empathy. And I'd love to talk about empathy and sympathy. It's one of my big things now. Yeah. We call it empathy, but we take these judgments. I'm going to meet you for 5 minutes. I'm going to decide based on what you're telling me whether or not I believe you. If I believe you, we have that helpful relationship you're talking about. If I don't believe you, I'm going to talk about you when I'm in my office. I'm going to tell other people what I think about you before they've met you. I'm going to use really insensitive terminology referring to them because I've decided as a practitioner that I am the only person who knows the truth. If I've experienced things similar to what they're describing and I got myself out of it, that's all they need to do. And if they don't do that, they're not trying. All of these different things that determine whether or not it's a helpful relationship. But the other piece, and I'll stop because this has been a long one. The other thing I want to say is that as the sick person, none of that's fair. I can't say that because you're not helpful, that if I don't find recovery, it's all of your faults. And this is where it becomes that insensitive advocate again. I've worked with plenty of people who were not helpful as a professional and as a patient. It is still up to me to do what I have to do. It's one of the hardest truths of being mentally ill and finding recovery is that you are labeled as someone who has limitations. You are told that you have these things wrong with you, and yet the majority of the responsibility of your wellness falls on you. Good luck selling that to someone on the other side of their crisis, but it's an unfortunate truth. So if that person isn't helpful to me, and now I'm not going to be a member of my own wellness because they're not being a member, I still have more work I can do. Accountability is a principle of recovery. So I agree, but when I was working as a peer specialist, I would continue to challenge people who would describe to me that they didn't have those helping relationships. What can you do? Right? It's a really simple question, but it's the reality. What can you do? If you want to advocate, go for it. Ask for another therapist. You're allowed. I support that. But if you decide to not care about your own care because you recognize that the person working doesn't care about your care the way you believe they should, you are now somewhat responsible if your care gets dropped. When I felt like nobody cared about me, I still had to. So it's a double-edged sword.
Yeah. No, I mean, I think that's a challenge. I wholeheartedly agree. And it is a very challenging message to get across in a way in which it's received.
It makes the suffering more. You suffer
yeah.
more. It makes something that's incredibly difficult more difficult. And if you look at it from the lens of fair, it's not.
It's not.
It's
And what's
not
the
fair.
alternative? I mean, no one else is going to look out for you in the way in which
Unfortunately.
you are able to look out for yourself at times.
You need them to. They're getting paid to. They should, right? They should. If they don't, what do you choose to do? I would not hold anybody to the fire if they were like, no one's helping me. I literally can't. I would empathize with that.
Mm-hmm.
I get it. You need to take a break for a while. You can't. I said, I was in bed for a year.
Mm-hmm.
I couldn't. No matter who tried, I couldn't. Sometimes that's the truth.
Yeah.
Right? When you can't, you literally can't. We don't often believe people. We're like, yes, you can. No, sometimes you really can't. That's illness.
Yeah.
That's any other illness. I can't breathe. You believe someone. I can't stand. You believe them. I can't get out of bed. Try harder. You know, it's amazing how we decide it. But it does. It makes something incredibly difficult more difficult. But this is why that proactive education is so important, because there is nothing that I had to learn faster than how to handle hard, because it's everywhere to this day. Because I didn't take the disability right after I got out of the cardiac unit, I started washing dishes with an active nursing license. First 30 hours a week, I realized I couldn't, then 20 hours a week at $14 an hour. That's not an appropriate wage for someone who's almost 40 years old. Who's
not a
also
livable
paying
wage.
$2,500 for a doctor, $600 for every blood test. They're having me do scans. They want to know what's wrong with me. They're trying to figure out why I couldn't walk for 3 days and bend at my knees. So they're having me do all this stuff, and I'm having to decide which test I should take, which test I shouldn't, because I can't afford all of it. I'm afraid to go into hospitals. All of it. It's incredibly difficult. But there's an empowerment when you still realize that you are the single most contributing member to your care. It's a challenge. And that might mean saying I can't. And that might mean learning how to assertively say, I don't believe this is a helpful relationship. I don't believe you are doing your job, which will create stress in and of itself because, you know.
But to adopt a passive stance in your own care won't serve you.
At times. We almost all have to do, this is something I've told my mom. All of us are challenged with doing the one thing we are least comfortable with doing. I'm non-confrontational by nature. Confrontation causes me great stress. At this point in my life, when I become stressed, I turn into a beast. Like I wake up every morning like this until I take my medication. This is how I wake up. I was an otherwise healthy human being. I had a lot going on with my mind, but my physical health was not in jeopardy. Okay? I don't believe that is my doing, but it is my life. So what do I do now? I can stop because it's that doctor's fault. And I can stop there for the rest of my life, but I am now contributing to the possibility of not reaching my potential. And if my sole goal in this life, regardless of limitations, is to reach whatever potential I still have, then I will not allow anybody, whether they've done right or wrong by me, to be the reason I don't pursue.
I work with a supervisor who I have a lot of respect for, and he's done this work for a long time. And what he does when he notices other organizations or even his own supervisees or whatever it is aren't holding their slice of the pie, right? Aren't holding their piece of responsibility in a given very complex case. He adopts a stance that isn't aggressive, isn't defensive, isn't antagonistic, but he adopts a stance that I think is a beautiful one. He says, "I'm pointedly curious," and sometimes anybody can see anything as aggressive, right?
Yes.
As a female, I'm often aggressive when I'm simply pointedly curious, and I can be aggressive too, but I often go for pointedly curious. And he is pointedly curious in many of those meetings when he feels as though a group of professionals has adopted a not it approach with a very complex case. And what he does is he will show up with the service description and the mission statement of the organization at which that individual works. And he reads that out loud at that meeting. And he says, "So you are so-and-so, and you work at so-and-so, and this is the description of your organization is this, and this is your mission statement. And can you tell me how you, in this case, are going to live in accordance with that mission statement?" And I thought that's just a very beautiful, not saying you're not doing your job, which in many instances they're not, but simply saying at the end of the day, this is your due north and this is one of your values. And can you please show me or tell me and commit to all the others around this table how you will, and I think most of these mission statements are beautiful, right? We often fall short of them, but most of them are wonderful. At PCS exists to help children, adults, and families discover their greatness. That's our mission statement.
Right.
How will I help this client discover their greatness? If I was asked that question seated around a table with my peers, I have some noodling to do, right? And so I think that there are times where different folks have different levels of adaptive functioning.
Correct.
And so, but I think to lean in and say, how will you help me in accordance to your role is a very fair question. And at the end, teaching folks how to be their own best advocate at times is all that we can do. And it sounds like that's something that you have learned throughout the course of your career. Now, you mentioned something throughout that you said you wanted to talk about, and I want to make sure we have time to get to it, when you said the difference between sympathy and empathy.
Right.
And so speak to that. What do you mean? What are you talking about when you talk about sympathy versus empathy?
We talked about it in the training that I did. Empathy, this idea that I'm going to put myself in your shoes, but I'm going to bring all of me, including my experiences and my thoughts. So I'm not going to, I'm not just going to stand in your shoes. I'm going to look at what you're experiencing and decide that if I was experiencing it, would I find it difficult? Would I suffer from it? Or would I get over it? And then I'm going to use my life experiences. I'm going to call it empathy, but I'm going to use that to be the judge and the jury on whether or not what you're describing is a reasonable thing for you to have left your job, not be able to leave an abusive partner, not be able to kick your addiction. And if I've kicked an addiction and here's how then I'm going to decide using empathy that you need to work harder or you're not doing enough. It's a lot easier than you're making it seem. That's empathy can interfere when it's done inappropriately. I also learned in my training at a recent job, don't sympathize. Sympathy is pity. No, sympathy is not only pity. Sympathy is you're telling me you're suffering. Here's compassion. Sympathy is far simpler than empathy. It's humble. It's selfless. I don't need to think about whether or not I could do what you're saying you can't. I'm going to stop at you telling me you're suffering. Realize my job is to serve people who are suffering and believe you. Empathy makes us lie detectors. And let's face it, the reason I lost disability, the reason I lost the medication I need is because some people do abuse systems, but not everybody does. No. So when you start to become that judge and jury and decision maker, just by looking at someone or maybe putting yourself in their shoes, you can call it empathy, but it's very insensitive. And empathy is not meant to be insensitive. Like I think I've already stated it, but you ultimately decide you're worthy of my compassion, you're not. You're worthy of my time. I'm going to try to help you get back to where you want to go. You need to just grow up. You need to just try harder.
Pull yourself up.
Yeah, sure. Which again, there's a lot of those tropes that saved my life. You know, there's a lot of things we've gotten rid of that maybe we need to say them more sensitively, but they're incredibly true. Life isn't fair. Like if I expected fairness, I wouldn't even be where I'm at. And I'm still washing dishes, by the way. Like that, I wash dishes once a week. That's it. I do trainings. I advocate relentlessly. But at the end of the day, I wash dishes with an active nursing license because I will not die any younger than I have to trying to fit into boxes that all these people who have worked with me have tried to fit me in. You're healthier than you are, then you're acting, you're more sick, you're very sick, you're not sick at all, you're not healthy at all. The amount, and it's every single time you meet a different doctor, they all send you on a different path. So I have to start making difficult choices. Luckily, I have a partner who is completely on board. And none of it's easy. That's the problem. We're looking for easy. We're looking for easy as clinicians, and we're looking for easy as people receiving service. We're looking for comfort as clinicians, and we're looking for comfort as people receiving service. We're looking for the absence of stress as clinicians, and we're looking for the absence of stress as people seeking services. None of that leads to actual recovery. It is work. It is uncomfortable. It is stressful. So as we lean more and more into whatever these new models are of, I should be completely comfortable throughout this process. I have no accountability. I don't need to challenge anything about myself. My clinician doesn't need to challenge anything about themselves. And somehow a solution is going to exist. That's poor. It might be difficult to offer sympathy to someone who you don't like. I've worked with people who have abused children, right? I've been the person on the floor where everybody's like, hey, Lewis is really good with them. I refuse to work with them. So then I end up always being the person taking that difficult, but I'm getting paid to work with someone who needs help. My opinions mean nothing. I'm getting paid to serve this person who is here at a hospital, and I am a nurse. So I don't have to have empathy. I don't even have to have sympathy to show it. We treat it like a currency. We treat our sympathy and our compassion like a currency that if you're worth it, I'll give you some. If you're not, it's mine. And I don't find that to be an appropriate approach in the mental health field. Empathy is what determines like the tip. It's like a tip. How hard did you work? How hard do I perceive that you work? Could you have paid better attention to me? I'm going to give you 10%. You were great. You were really nice. I'm going to give you 30%. That's not what compassion is. I'm going to give everybody 100% because it's my job. Sympathy cuts out the middleman, which is actually us. Sympathy keeps us out of it. Just says, this person's here for help and I'm here to help them.
And I'm going to show them compassion.
Here's compassion. I can think whatever I want. I can say whatever I want when I'm off the clock. Here's compassion while I'm here.
I don't know. I don't think we should say whatever we want when we're off the clock. Well, I'm gonna press back on that.
That's not my stance.
Yeah, no, and I know it's not because I think that also. I mean, I think at the end of the day, we construct. I mean, I'm a pretty big believer in like constructionist theory,
sure,
and like the belief that our histories and our stories and our beliefs and our social location and all of those different things come together to construct our narrative of any given event and create the lens through which we perceive and experience others. And basically, I think we all walk through life with multiple impressionistic paintings of the world around us, and that nobody's reality is truly reflective of reality. And I think, honestly, increasingly so, we're getting even less and less reflective of
100%.
true reality. I
Yes,
think
we are.
we are getting even further and further away from each other because we are getting more and more insulated from one another. I think as we all turn in on ourselves and on our phones and whatever else, we're being fed different realities
Yes.
that then create that perception and that lens and change things. But I think the language we use is so important. And I have walked into treatment team meetings and heard the words
Yes.
that providers use to describe the people that they then are going to go sit with, as those people talk about the worst days in their lives. Or I've seen descriptions of, even like one of my area of specialization is problematic sexual behavior. And I have heard people talk about these individuals who are also treating these individuals. And I don't think anyone should harm a child.
Correct.
I also don't believe healthy, well-adjusted people harm children.
Right.
And so I can abhor the behavior and think it's absolutely disgusting, and firmly believe that if you've harmed a child, there should be very severe consequences
Yes.
through the legal system. Right. I don't think we should like set fires on your front porch or what, you know what I mean?
Right.
Vigilante justice is not for me, but I
neither.
think we need legal ramifications for those folks, and not to protect them. But I think the language we use when we discuss those cases is important, to the point where even when I'm doing a supervision and my supervisee comes in, oh, well, I've got a sex offender to talk with you about. I was like, who do you have to talk to me about? You mean a client with problematic sexual behavior? Let's start over. Because I do think when we define somebody as a monster, then they become the monster. And if we define, and maybe they are a monster, but I don't have a crystal ball.
Right.
And I don't get to decide how their story ends. They get to decide how their story ends. And so if I define them as a person where one piece of them is this dark, ugly, horrible thing, but maybe they've got these 3 or 4 other tiny little glimmers of light. If we can grow those things and extinguish this one, then maybe we've got a shot of them never hurting another child again.
Sure.
And maybe we don't. Maybe they are just a fucking monster. But I don't get to know that.
Yeah, and depending on what they've already done, again, like this goes back to accountability.
Yes.
I don't believe they're starting to have more of these 24-hour crisis centers where we're going to bring you in.
Yes,
We're going to
yes.
work on you, and you're going to leave. But some of us need to stay for those 2 weeks. Some of us need to stay for that month. Some of us need to go to places based on what we've done. I've
Yes.
done things that I shouldn't have done, and I've lost my place of where I was. I've lost jobs. Now, I can say that's not fair. I'm mentally ill, or I can look at my behaviors and say, that's fair.
Yeah.
And we have to all decide kind of collectively what we're going to do. But problematic behavior is still problematic regardless of the source. Yeah. And if people are at risk or if it's inappropriate, it's not necessarily okay to excuse it because I have this diagnosis. Yes.
Yeah.
So I've lost jobs, I've lost relationships, I've lost friendships. And just hearing you talk about those different paintings and how we all have that constructionist view, I want to challenge that in general. When you clock in, how important is your view? Because part of us turning in on ourselves is this belief now that it's really important what I think. My opinion is so important that all of them need to be spewed out loud. And I have every right to share. You do. You have a right to share whatever you want. You can share as many of your opinions as you want. How important is it actually? This whole concept of dialectical, I'm really hooked on it, probably because I'm bipolar. You are incredibly important, and then you are also just one of many. So another thing you have to learn when you're sick is humility, right? And you want your practitioners to also be humble. Your picture is important for the rest of your life. Absolutely, I'm not trying to discredit that. How important is it while you're here caring for other people?
Oh, I think it's important from my perspective.
Sure.
The important part of your lens is to know it and account for it.
Yes.
And to be aware of it and to recognize where all of those different pieces lead to your biases. And then ultimately, I think that's why our evidence-based practices are so important in therapy.
Sure.
Like, that's why we use therapeutic models. That's why we use theory. That's why we use like research-based practices so that we don't get in our own way.
Right.
And so hopefully those lenses don't have more power than they should.
Right. I think what I'm saying is that if you recognize these biases and then you are affirmed to stand in some of them.
Oh, hopefully not.
Like, this is who I am.
Hopefully not.
Right? So I don't have to do that, because this is another part of the way mental health is trending, is that we're now aware the therapist's mental health is as important as the mental health of the person they're caring for.
Yes.
Right? So what that does, I'm not saying that's wrong, but now the therapist during work hours sometimes might take those stances for their own mental health, and those stances could inadvertently, unintentionally interfere with the care of other people. I'm not saying it's right or wrong, but as we grow our understanding of mental health, you now have the people offering service thinking about whether or not they're being appreciated enough, whether or not they're being compensated enough. They're thinking about themselves while offering service, which in and of itself is somewhat selfless, right? And that's a very difficult thing, I would imagine, to navigate as an administration, because you can't really say either side is wrong, but somebody's coming in on the other side of a crisis. You're coming in from your home to do your 40-hour-a-week job. It doesn't minimize your opinions, your experiences, your lens at all, but I do have an expectation of you to be able to work this 8-hour shift and to help these people whose lives are actively falling apart. And that might mean that those people might call you names, they might hurt your feelings, they might poke your triggers, all of this stuff. And you shouldn't have to endure that without it being addressed. But at the same time, you're here to care for them. They're here to receive care. And I think that that subject in and of itself is worthy of an entire conversation, because where do we find that line? The teacher and the student, the police officer and the person that they're dealing with, the nurse and the patient, the doctor, and all of it.
There's an inherent
They're all
power
human
imbalance,
beings, right?
And therefore, there should be a level of professional distance.
Professional distance and an ability to leave some of yourself at the door and bring your service self.
Yes.
Again, the amount of political stuff I would hear in my office, seething, venomous stuff, regardless of what side you're on, insults to the intelligence of one side or the other. Everybody talks about stuff as if they know what everybody in the room must agree, because they're so seething in what they're saying. They don't realize they could be insulting anybody who doesn't agree. And this is all, does that need to happen here? Does that need to happen now? Does your opinion of why a patient is behaving the way they're behaving, is that necessary? If it's not based on anything other than your conjecture, this is what I'm talking about as far as how important are your thoughts. And I would say this to everybody. Our brains think the same way our digestive tract creates gas. This is what I talk about this in my groups. Some people are proud of their belches. They do it really loud, right? As if it's something they've done. No, this is how your body works. Our mind generates thoughts as long as we are awake. How much credit do we need to give every single thought? Or are we able, something else that you would ask anybody mentally ill to do, Are we able to say, that doesn't need said, that doesn't need said, that doesn't need said, that doesn't need said, that doesn't need said? I lived my life micromanaging my emotions and my thoughts because I was almost made to believe I have to in order to be discharged. If I talk over, if you're sitting in a group and two people are talking at the same time, you're going to be told, hey, let them talk first. Then you can talk. And if you keep talking while they're talking, you get kicked out of group. Go ahead and turn your TV on. Who's listening? Everybody's talking at the same time, right? So when you think how important is your opinion at any given moment, especially if you're in the service role, I'm here to help. I don't need to know every why. I don't need to know every how. I need to listen and do my role. If I do have to talk, I should be allowed to. And I think that's what I meant when I said, when we're off the clock. I have every right to say what I need to say to maintain my own health.
Yes.
But how important is it on the clock? I've never said I'm not getting paid enough. I've never felt like I'm not getting, I might have felt like not getting thanked enough, but then I think, well, I'm working on a psychiatric unit with people whose lives are falling apart.
Gratitude's not.
I
at the
don't
top of the
need them
list.
to thank me to stay here. I don't need them to be happy. I don't need them to laugh at my jokes. I don't need them to compliment what I'm wearing or say I'm doing a great job. Their lives are falling apart, and I'm here to help them. So again, this is where it can be perceived as insensitive, but it truly isn't. I have a very idealistic belief of service, and I have chosen a life of service. And service is often, to a degree, humble and selfless.
No, and I think that very much agree with that piece. And I think in many ways, the only way out is through. In that,
It's on one of my bracelets.
oh, is
Yeah.
many of our providers do, like, those encounters do evoke something in them.
Of course.
But instead of ever talking about it in a context appropriate space, we shove it down and away, down and away, down and away, and then it comes out sideways. And I remember a couple of years ago sitting with like 3 early career clinicians, and I've been doing this for longer than a minute now, and somehow it came up, like, I was like, well, how often do you cry in your car at the end of a shift? And they're like, what? Like, it was like I had 7 heads. They're like, what do you mean cry in my car at the end of a shift?
Right.
And I was like, oh, I used to cry like 2 to 3 times a week. Like, literally, like, and I'm a crier. Like,
Sure.
if I mean, I don't love to cry, but I feel like it's cleansing. I just feel like
Absolutely.
tears are a good antiseptic. If I've got to cry, I put on some good bright eyes and I get it out.
Yes,
Like,
yes.
let's do it. And so I lean into it, and I always have historically. And I cry a lot less professionally now, but I do it when I need to. And all 3 of them were like, what do you mean cry over work? I mean, well, sometimes our work is really hard. And sometimes the people we serve don't get well, and we care about them on a human level, and it hurts. Or sometimes over the course of serving them, it hurts. Or sometimes the system is fucked and it hurts. And then we cry. And you literally never cry. And none of them cried. And I'm still like just gobsmacked by this
Sure.
belief that it's somehow wrong to be a professional and to allow the work to hurt in and to go to supervision and let it hurt there, to go to a trusted colleague and let it hurt there, or to call up. I mean, honestly, I would call my mom and be like, Mom,
Yes.
today really was hard and I don't know why. Like,
Yeah.
and that was a space for it. And I wouldn't disclose content or violate confidentiality, but I would cry to my mom. And,
Right.
and I don't know, why don't we cry more as providers?
I think you nailed. I do think it comes out sideways in relationships. I mean, there's always been studies on people in relationships with therapists, and you know these different issues that arise from someone who works that closely to high energy emotion.
Yeah.
I would point towards a double standard of we're not crying because we are actually not recognizing appropriately the way we're expecting the people we're working with to recognize appropriately. So you literally don't think You're like, yeah, I know that happens to other people. It's not me. It's what we tell our consumer base not to believe. This idea that, yeah, it happens to other people. It's just not me. Then all of a sudden you're in a fight out of nowhere over a small disagreement that is now a 5-hour argument with your partner, because it is going in there. We're all sponges to a degree. And you know what happens if you leave a wet sponge wet? It stinks. It's stale. It's stale energy. So you might be someone, based on the life you've lived prior to becoming a professional, who was able to recognize emotion in its immediacy, address it, acknowledge it, process it, and remove it, which is a skill set that we would teach to our consumer base. But then you have a ton of people who are working in the field who literally don't think it's them until it's all pouring out, absent of control. It's nonsensical, it's intense, it's loud, it's stress-inducing, and it's based off of over and over again believing it's not you until it is. And that's so many things can point back to, are you able to practice the skills that you are making the people who you're caring for practice before you give them their pass to leave? That's one of my biggest pieces of advocacy. Are you doing what you are making the people you are labeling sick do? You're telling them they have pieces missing and they still have to do it. You're acknowledging you don't have the same pieces moving. You're not doing it. You want to talk about fair? That's not fair. And that's one of the greatest frustrations. One of the reasons I advocate is I want to take everything that gets taught in the safe spaces of hospitals or a therapy office and say, no, everybody needs this to a degree. Everybody should be practicing some of this to a certain degree. You do not have to be sick to practice wellness. You do not have to be sick to understand communication, how to speak, how to listen. This stuff, you literally, I can tell you, you're not allowed to always leave a hospital until someone thinks you can do these things. I look at cognitive distortions. I wrote a book about cognitive generalization, emotional reasoning, personalization, all these different things that I had to do CBT for years because I had so many cognitive distortions. And I wasn't allowed to have my certificate of completion until I did not showcase certain intense emotions and reactions when things happened. I see cognitive distortions everywhere. If you're this, you're this. If you believe this, you're all this. If you're it's massive. Generalization is a massive one. Polarization is a massive one. These things were proof that I needed help. These things were proof that I needed more meds, or that I needed to go back to the hospital, or that I needed intensive outpatient because I wasn't better yet. And yet everybody who's in control, everybody who's in power, my bosses, my teachers, none of them are confined to those same rules. It's like completely different rules. I have to jump through more hoops, and I'm also the sick one. You get to believe yourself to be healthy. Yes, you will suffer. You will feel anxiety. You will feel depressed. The human condition is difficult. But I have to carry this label, take all these meds, have all of these side effects that I will live with for the rest of my life. This experience, whatever the hell it has been, I don't have the house. I don't have the kids yet. I don't have the car. I don't have the full-time job like so many other people. But I was held back multiple times for showcasing what many showcase on a daily basis. So what makes us pluck certain people and say they have to prove they can do it and other people don't? One of those skills would be the processing of emotion, the management of it, so that you don't allow it to spill over and cause harm to anybody in your blast radius because you've pushed it away and compartmentalized it until the point that it explodes. Now you're literally causing harm to other people because you have not dealt with it in an appropriate manner. If I would do that, it would be a warning sign.
I once, so at PCS, we do leadership trainings for our executive, not just executive, all our leadership staff, including administrative and clinical leadership staff. and I did one once all on DBT skills and how we can use DBT
So good.
skills in the workplace.
Anybody,
Because I'd like to see everyone
everyone,
use DBT skills in their leadership.
no
Because I
matter
think
what.
addressing performance is hard and we get dysregulated. And I think if we were to use those skills in our leadership, we would be more effective leaders. It was probably the lowest feedback I've ever gotten on any training. And it was because quite a few folks said, I don't know why you're teaching administrators how to do therapy. And I went back and was like, y'all missed the whole point.
Yes.
The whole point is I don't want you to do therapy. I want you to do this to you.
Learn skills.
I want you to do the
Yes.
skills. And I think we've come a long way. And I know that my kiddos, they're not in public school anymore, but when they were learning DBT skills in kindergarten, in the school they're in now. It's amazing when it comes to teaching more soft skills and pro-social, like
Yes.
how to. My kiddo is in second grade and he came home with a whole worksheet on how to do an apology, how to set a boundary, how to ask for help, like just a lot of soft skills that very much mimic the DBT stuff.
Right.
So I think we're, in many ways, as a culture, kind of going the right direction.
I would
but
have a slight
we're not
pushback,
there
and I
yet.
know they're young, so that's a great start. But what I see as the problem, many people can set them now. Can you receive somebody setting them?
Yes.
Right? So it goes back to the both. Not only learning how to say, here's what I need, please don't, but learning how to hear, please don't, without it hurting your feelings. It's another chain reaction that I often see is that you have a well-intentioned person who does something that hurts somebody else. That person says, ouch. That person's ouch now hurts the person because it wasn't their intention to do anything. So then instead of saying sorry, they're now sad, right? And it happens so much. Now the person who got hurt is trying to calm down and soothe the person who hurt them because all they did was say, please don't do that. And that please don't do that wrecked the brain of the person who did something another person didn't like to the point that they became unregulated. And now their feelings are hurt because I didn't mean to. The amount of times I've heard, we're trying our best. It's so difficult to be in my position. It truly is. And there's tons of people who are in this position where you can literally not reach certain benchmarks, even if you're trying your best, because you are held to a standard of you're either doing it or you're not. And then you have to allow everybody around you to say that they're trying their best and thank them, even if their best or their good intentions are harmful. If you try to express how it hurts, you hurt them. So there are a lot of people with mental illnesses who, for the sake of a better term, are coddling everybody around them who hasn't learned the skills yet, which then makes them the caregivers while they still need care. And that is my life. I am constantly offering care while still truly in need of it. I feel at risk all the time. There is no way to replenish the amount of resources I have to spend on a daily basis. And more often than not, I am just deemed healthy. When I work with community organizations, if you have a parent and someone and they have a sick adult child, the parent will think I'm their peer more than they'll think I'm their child's peer. I believe I'm their child's peer. But because of how I might speak, because of how I might present, it is quickly forgotten that I'm sick. And like if I get tearful, I'm not triggered. I just have to almost neglect myself, which goes against self-care, but it helps me maintain self-preservation. If I was to speak up about everything that actually was harmful to my recovery, I'd be having difficult conversations 5 or 6 times a day at my home, with my friends, with my family, with my employers. So there's so much you have to swallow. And then I'm doing all of that to make $16 an hour, which doesn't even pay my medical bills, and most of it's because people just decide I'm not sick again. I told my wife this morning, I had to remember to tell you, in 2025, I don't think I've ever had to say more, I have a mental illness out loud. And that's very frustrating to me because it's not something I like to identify as. It's just something that I have. But I'm constantly feeling like I have to remind people that I'm sick. And sadly, a lot of the responses I get are, so am I, or, even in hospital settings, we all have something. We're all in recovery. And it's like, there really is a threat to people who have lived with mental illness for a long time as awareness grows and more people start to focus on their own suffering. Because then those people who literally have these chronic diagnosed illnesses are looked at exactly the same as everybody, even though our life, if someone's life path has just been this and maybe it stables out, mine has literally been this, and that is with diligent, hard work, difficult choices, not spending money, fiscal responsibility. Like, this has been my life, and that's responsible. This is my life as a person trying to be responsible with my illness. It's not possible for me to live this way. It might be at some point, but if I've had to live like this, and then I kind of reach the person who plateaus, now we're equals, or it's all very difficult. People fight for that equality, but they also want you to remember that they're sick. It's really difficult. And we are oftentimes fighting for the same cause in opposite directions, which is what's making offering mental health care more and more confusing and difficult as well. We want that independence. We want you to treat us like everybody else. We also want you to remember we're different. That's counterintuitive. And that can make it really difficult.
Well, I think to speak to one of your earlier points as well, then once you arrive at that plateau point and show any sign of gains, we remove the resources that allowed you
100%. You're better
to get those gains. Yeah. And so now stabilization or maintenance of stability implodes.
Yes.
And I felt as though in this field we had made some gains in that area, at least from when I came into the field. Early on, any sign of gain. And I started my career working with the autism community. And so if kiddos had services, if they showed any improvement, almost instantly their services would get cut. We've gotten a lot better in recent years. Now, my fear with some of the insurance changes, and we could talk about that for years, and we won't, because otherwise I'll probably start crying and screaming simultaneously. That's a different conversation, but my fear is we're going to head back to that space at some point in time. But what I'm understanding in our conversation is that maybe we've made those gains in the autism community, or we've made those gains in services for children and adolescents. But I think for adults living with chronic mental illness, I don't know that those gains have been as present for that community. And as we look ahead to some of the changes we are going to see legislatively, some of the changes we're going to see with access to medications, some of the changes we might see coming down the line for access to healthcare, I don't know. What advice do you have for living with chronic mental illness with some of the uncertainty in 2025 and beyond? Knowing what you know.
It just goes back to really, first of all, hope. And hope is a belief. It's the hardest thing you can teach people. But if I didn't have hope, I do not believe I would still be alive. And hope is I don't get to decide how long I live in a state that I'm not happy with. Right? I might only be able to tolerate distress for a month, and I might live in distress for 3 years. I've lived in a distressed state for years at this point. When I lost my disability, I have been under distress. I have still been doing everything that I have to stay afloat. I equate it often to treading water, right? When you get really good at treading water, it's like a duck. All you see above the water is this duck who looks still and calm. You don't see under the water that they're doing this. And to extend the metaphor, lots of people come by me in their boats, and they stop and they talk to me and they say hi to me. And some of my advocacy endeavors have now led to trying to be artistic, because I believe that at this point the only way to get people to truly pay attention is to entertain them at the same time, which is sad, because this is like possibly life-saving or life-altering information. So I literally have to be like
Yeah.
juggling. So now I'm treading and juggling. The people, they come by on their boats, they watch, wow, that's really impressive. And then they just
A
keep
juggling
going.
duck. Look at
Yes,
that.
right. Nobody offers a hand up. I had a plank that I could rest on. That was taken from me. So my advice is you've got to decrease your expectations and not embrace suffering, but my expectation that on any given day I won't suffer would set me up to then be disappointed. I am suffering. I lost my disability under a different administration. Like there have been a bunch of different presidents throughout this part of my life, and I've just suffered. Most of my life has been suffering. That is not to say I don't experience joy and happy moments, but I have been misunderstood, misperceived, and more often than not, unintentionally mistreated because of others' perceptions. It is still my goal until I draw my last breath to try to pursue as much as I can. If I allow people that I have no way of communicating with, like the highest levels of government, then I will give myself permission to give up or make my suffering worse. So a lot of what I do is still local. I get involved in organizations. I don't agree with the leadership stances sometimes. You have to be a follower before you're a leader. You have to admit some realities. If I work 2 days a week and there are people who work 60 days a week, if I work 2 days a week and there are people who work 5 days a week, why does my voice shouldn't be louder than theirs? I'm not more important than them. There are a lot of people contributing to everyday life who deserve a voice. So recovery isn't about becoming more important than other people. And being sick isn't about being less important than other people. There is a necessity to assimilate, but there still needs to be a recognition that we're different. I'm sick. So I equate that to a bike lane. If there's a bike lane, I should be in the bike lane, right? I got to let the people who need to drive get to where they're going. 40 hours a week, 50 hours a week, that's way more. They're contributing daily to society, something I'm not able to do in the same way because of my limitations. If I'm on my bike or I'm walking and I'm not using the bike lane because I think I'm of an equal contribution, now I'm holding up lots of other people, and that's not fair to them. So there needs to be a true understanding that we all have a place, that our places are different, that we are not more important or less important than other people, and that I just believe that everything I've stood on for the past 15 years has been accurate, and it still hasn't been credited appropriately. And I can either give up or not. I mean, I hate to simplify it. I have to make tough choices. I've had to leave jobs. I don't believe that any singular implosion in my life has been solely my fault, but because I have a diagnosis, everybody looks at me like I'm the only person involved in the failure. I don't often tell other people's faults out loud. I don't share the true dysfunction. I don't bury the people who I believe are equally at fault or at greater fault for some of the failures I've been involved in, because I don't find any of it to be helpful. It's hang on. When you're surrounded by darkness, believe that there is still light. Have hope. Do honest assessments of what you're contributing, what you're capable of. And some of that stuff is difficult. And then learn discomfort. Learn it. I will devote my life to trying to live with less suffering and distress. But until then, this is my life. And my choices are to give up or try every day. My choices are to give up or try. So I have to be honest about how many hours I can work. I have to believe that what I have is real, whether other people believe it or not. A lot of people don't believe I have a neuromuscular disorder because of the way I look. If for some reason I'm having a good day and I can go for a run, everybody looks at a modicum of success as proof that none of the negatives exist. So you can't get caught up in what anybody thinks about you. At the same time, it matters what they think about you because you're trying to assert yourself back into your community. So it's all a really hard ask. It's hard to give advice. Here's something that I will say. Part of the reason I'm sick is because a lot of people didn't give me what I needed when I was young. And they didn't give me what I needed, not intentionally, but because they didn't know how, or they didn't recognize it to be as serious as it may have been. As someone who is now older, negatively impacted by that, if I deny other people's what I know they need, and I know they need it because of everything I've learned, I'm doing it intentionally. That makes me worse. So there are people in my life that I make sure don't feel what I felt, even though they made me feel it because they did it by accident. I'd be doing it on purpose. So it's grace, it's hope, it's all of these things that are born out of beliefs. There is no proof of them. You can't do studies on them. I can't give you any, but I choose it every day. And the one thing I'm probably rich in is integrity and relationship. All of the people that I could have been mad at, all of the bridges I could have burned, I didn't. Some of it was out of preservation. Again, if you're living under someone else's roof and you believe that you should make the rules, you can't always be entitled and helpless at the same time. You've got to learn compromise and sacrifice and long periods of time doing things that you don't agree with or like, but it's not your dime keeping the lights on. You know, I've couch surfed. I've lived with my parents as an adult. If they said no girls, even if I'm 30, guess what? It's their house. So who am I to fight? They're putting a roof over my head. I think that we get caught up in wants and needs. So that would be the other part. What's a want? What's a need? What do you need? What do you want? And I think we're living in a time where those lines are getting blurred, where we don't get what we want and it feels like we're not getting what we need.
What would you say, or sort of anything left unsaid, anything that at this point you were hoping that we would talk about that we haven't gotten to yet, any other missing pieces before we end here today?
Yeah, I do feel like within central Pennsylvania, I feel that I am someone who in 2009, that was the first time I spoke to an elementary school classroom. I've had my finger on the pulse for a really long time. And I'm still not getting opportunities to work within the communities with parents, with students. I've gotten my nursing degree. I have a professional resume. I've maintained my course, and I've righted my ship everywhere that I've had to as far as my behaviors and the things that were unsavory based on how I acted in manic episodes and things like that. We're living in a time now where if you are a great football player or a really famous artist, that you get invited to talk about mental health, even though you have no other expertise, you're just already famous for something else. Or you have a really sensational story of suffering, surviving a suicide attempt, for example.
Yeah.
And you get called in and you get to stand on a stage and talk to parents and teachers and students about stuff like suicide prevention. I desperately want to work in those spaces as well. I have suicidal ideations on a daily basis. As I said, when you live in distress, you often think this isn't worth living. What the hell is this? It's exhausting. It's suffering. So to me, prevention is having those thoughts and not going through with any of the actions. Understanding your resources, being able to communicate, being honest with yourself, being honest with others. I want there to be a space where people with clinical knowledge and people with experience can coexist. And as we grow into this awareness, I don't think we should just let anybody who's had a panic attack or a fleeting suicidal thought or a severe crisis get to be an expert and offer advice to a public that, for the sake of a better term, is ignorant, not negatively, ignorant in the sense that they've never learned any of this. I want people who are trained to be speaking as much as people who've had experiences. And in my case, as somebody who's both, I am slightly frustrated that I have to drive out to Lebanon or Philadelphia or York. I'm constantly having to leave a 3-mile radius of my own home to do what I believe I'm here to do. And I don't understand it. I don't fight it. I don't badmouth anybody, but I want anybody who listens to this to consider the idea that we can't all be experts just because we've had individualized experiences. There is more to it. You're a clinician, right? You know more than I do. As an RN, as a CPS, at least in a certain direction, right? In my opinion, the best relationship is a doctor who knows a ton about psychology and a consumer, patient, peer, whatever. I've never been offended by the word patient when I was in a hospital, but I don't want to sound insensitive. Someone who knows about themselves. I want you to know about the field, and I want me to know about me. Yeah. And then we work together. But there is a place for clinicians that's missing. And we're starting to have, it's almost, you were talking about reality becoming relative. And I wrote in one of my books, if reality becomes relative, it will render itself irrelevant, right? I don't want mental health to become some relative term where you have, let's say, 10 different people who are licensed therapists, and they're all offering 10 completely different takes on the same subject. To me, that is not science as we understand it with any other illness. And that goes back to the beginning of this conversation where we need to treat mental illness like it's illness. If it becomes a complete opinion across the board, and the person who's experienced it knows as much as the person who went to school for 10 years, and your kid is listening to the person who says what they want to hear, or the coolest person, or the ex-football player who's a Hall of Famer, and he's talking about it and giving advice, and this clinician, I think that is unsafe and irresponsible. It needs to be a slow approach to anybody who has never reflected and entered into their own thoughts and emotions. It can be incredibly overwhelming and off-putting if it is done too quickly. Yeah. We talk about sickness before we talk about wellness and skills. So there's a lot of it that's being done, and I think it's being done well-intentioned but irresponsibly. And I want people to consider awareness in general, what it's actually done. Are we better or worse than we were 10 years ago on this front? And is it time to think about different approaches? So that would be a cheap plug for myself, but I believe that I've earned it and I will continue to, whether those opportunities arise or not. But within a 3-mile radius, I don't understand why I'm underutilized.
No, and I mean, I think to give to double down on your cheap plug for yourself, I think to say, I think a few moments ago you referenced how you moved away from like the voice to ear model and you moved into a more artistic expression or a more artistic model of education, and the juggling duck, which I think will be a metaphor that'll probably stick with me forever. But I don't disagree with you though. And I've often, I think if you look at my trainings and my education of clinicians and providers, it's evolved from being very like research driven and education driven to trying to put funny spins or interesting ways to communicate to make it bluey clips or whatever it is,
whatever
right?
you have to do.
Whatever you have to do. But I do think we live in a world with increasingly smaller attention spans, and so I think you have found a way. I think artistically and musically you found a way to educate, and I think there's a lot of space for it. So also once we have this all edited, we'll make sure that we link some of that at the end, because I think some of your music is a great way for people who aren't ready to sit down and listen to the story.
Right.
I think to sit down and hear the song and maybe through that hear the story. I think there's a lot of value in that as well.
The reality is you can do as much work as possible, but you can't walk into, you need to be allowed into places. You need to be invited to them. And sometimes if you hear a song or you hear me talk about the musical I wrote, you can't put it together unless we actually have a conversation about it. And if I'm never able to talk about it, then I might look like a starving artist. But the only reason I'm trending towards artistic means is because of that decreasing attention span. A teacher once said, you teach the class you have, not the class you want. I am more than capable of just speaking on it. But if I need to sing and dance for people to receive the message, I'm willing to. I'm one of those artists. A lot of people say, I don't care what other people think about my art. My art is literally just a means of conveying a message that I believe is incredibly important. So I am always paying attention to how people are receiving it, because it's the message it's important, not how I have to convey it. So you write the books, and then you see what people think about that book. Then you write this book and you see what they think about that. Then you start to realize people want it in audio because they don't want to read anymore. So now it's like, oh my gosh, well, I guess books are done. Long form podcasting, maybe people listen, maybe they don't. So now it's like, so now I'll write a musical. Now this, now that. I'm willing to do that because of my belief in the importance of the mission. And one other thing, we're too fragmented. We have too many people with pet projects, all for the same cause, all moving individually. The problem is serious enough that we need to combine efforts. And we need to find ways to pick out which ideas people have that are feasible, cost-effective, and start collectively sharing our resources and working on stuff together. I created this musical. It could be done in a room this big. It's not elaborate. It's not going to be expensive, and it is impactful. So we need to start thinking about what's cost-effective, and whether or not your name is attached to it has nothing to do with whether or not it's worthy. Like it's be a part of something. Whether you get credit, I don't care if I get credit. I want to push the ball. I want to move something forward. We all, someone will always get to put their name at the end of thousands or millions of people's work, right? But if those people that we might not know their names, if they didn't do the work that they did, we don't get to the point where someone gets to say they completed it. And we're not always going to live a life where we're going to be the face in the history books. And I fear also that we do have a mindset where we want to be recognized for our efforts. And sometimes our efforts are just to move something closer to the goal and hand it off to other people who might end up getting credit. If you care enough about the goal, then just let's help move it, and worry a little bit less about credit.
I want to thank you for coming in here today, having this conversation, telling parts of your story, talking about sort of the state of mental health care in 2025 and ways in which providers can look at the peer support model and rely more effectively on peers, and just all the spaces in between, and the juggling duck metaphor, which I will probably maybe steal, but appropriately credit moving forward. So thank you very much.
Let them on the boat.
Get that duck on the boat.
If it's that impressive, make sure they don't drown.
Get the duck
because I'm drowning while I'm laughing.
I'm drowning. Thank you very much,
Yes.
Louis.
Thank you.
So at the end, please check out the links that we have available for you. Again, I'm Kim Ernest. This is Louis Bianco, and we thank you for listening.